Now let's get started. Good morning, good afternoon, good morning, and good evening, everyone, and welcome. My name is Dmitro Stepensky. I am American Society Microbiology Ambassador to Ukraine, and it is my great honor to moderate today's guest lecture, hosted under the initiative of the American Society Microbiology in Ukraine. And today's session features a globally respected leader in infectious disease, physician, researcher, and author, Dr. Breda Spelberg, Chief Medical Officer at the Los Angeles General Medical Center. Dr. Spelberg is one of the world's most influential voices in the field of antimicrobial resistance, and his talk, Shorter is Better, will challenge conventional thinking and introduce us to powerful evidence-based strategies that enhance clinical outcomes while promoting responsible antimicrobial stewardship. So today, he'll guide us through the clinical evidence behind the shorter antibiotic courses and what it means for our practice, stewardship, and global health system. So this event is open for students, clinicians, faculty, and also public health professionals. And we're grateful you guys all here. So please feel free to post your questions in the chat throughout the session, and we will address them during this session. So Brett, screen is yours. Welcome.
Dr. Stepansky, it was so nice to meet you recently at the ASM meeting in LA, and I very much appreciate the invitation to address your colleagues. Just putting the slides up here about one of my favorite topics, which is the appropriate duration of therapy. So when I give this talk, I like to start with reminding people why this is important. So what this slide shows you is the death rates of various types of infections before antibiotics became available and immediately after. There is no other intervention in medicine that causes an absolute reduction in death of 50, 60, or 70%. Number needed to treat to save a life of less than 2. There's nothing else in medicine that's true of. Actually, the one that I find people are most surprised by is this one. A simple cellulitis in the pre-antibiotic era killed 1 in 10 people, which is insane when you think about how common cellulitis is. When antibiotics became available, that number dropped to well under 1%. By comparison, in 1988, the ISIS-2 study was published. This was a multi-centered randomized placebo-controlled trial of aspirin or streptokinase for myocardial infarction. What was the death rate from MI in the placebo arm in 1988? 12%, which means that before antibiotics became available, skin infection cellulitis was as deadly as a heart attack. And antibiotics are much more powerful at reducing death from skin infections than clot-busting drugs are from reducing death from MI. Nobody remembers this. These reductions in death for individual diseases explains why, at a population level, the death rate from infection massively plummeted as soon as first sulfa drugs and then penicillin became available. The reduction in death was so fast and so large for infections that by the time the 1950s came along, and that was the decade that all types of intensive care medicine, mechanical ventilators, central venous catheters, pressors, all that stuff barely budged further the death rate from infections. That is how powerful the effect of antibiotics was. And the problem, of course, is that the more we use these drugs, the less effective they become due to the spread of antimicrobial resistance. So if we continue to waste them, we risk this curve going back up the other direction. Indeed, the person who discovered penicillin warned the public in 1945 that people were wasting it. They were breeding out resistance. The resistance was killing people. And in his words, the people wasting penicillin were morally responsible for those deaths. That was 80 years ago. We're having the same dadgum conversation today that he began 80 years ago. And in fact, what we're doing isn't working. All the enthusiasm around antibiotic stewardship hasn't worked. We're using more antibiotics than ever. We're using broader spectrum antibiotics than ever. Things are not getting better. They've gotten worse. So it was really Lou Rice in 2008 who gave a keynote lecture at a national meeting in which he first suggested, look, man, it's really hard to convince doctors not to prescribe antibiotics at all. You don't win a lot of those arguments. Maybe if we focused on duration of therapy, we'd win more of the battles and do more good. We'd reduce antibiotic use more if we focused more on how long to treat for rather than whether to treat or not. Dr. Rice also pointed out that if you only focus on trying to stop antibiotics in patients who don't need them, you don't do anything to help the patients who actually really did need the antibiotic. They just didn't need it for 2 to 3 weeks. Whereas if you focus on duration of therapy, you help the patients who needed the antibiotic. They only need it for 5 days instead of 14 days. And yes, the patients who didn't need the antibiotic, it would have been nice if they got none, but they're still better off getting 3 days than 14 days. So he pointed out you'll help everybody if you focus on duration of therapy. This was really the origin of what eventually became the shorter is better movement. But the movement was branded with the name Shorter is Better with this editorial published in 2016, which accompanied a randomized controlled trial that I'll show you in a couple of minutes. In the editorial, the question I asked was, when we come up with these durations of therapy, 1 week, 2 weeks, 7, 14 days, what is that based on? Where's the evidence for that? And so I looked at national guidelines and I looked at their references and I looked at the references of the references, and I traced the 7 to 14 day duration of therapy back in time to the fact that in 321 AD, Constantine the Great decreed there would be 7 days in a week. That is why doctors give antibiotics for 7 or 14 days. If good old Constantine had decreed a 4-day week, we'd be giving 4 to 8 days of antibiotics and there'd be a lot less antibiotic resistance. And we'd also only have 2 work days before the weekend, and that would have been really nice. But he didn't decree a 4-day week. He decreed a 7-day week. So when I'm on rounds and my residents ask me, how long should we treat this infection? I say, well, how about we use 1 Constantine unit? I call them Constantine units to underscore the absurdity that this is the evidence of the durations of therapy we're giving to patients in the year 2025. It's insane. Now, to be fair, not everybody uses Constantine units. There are people who give 10 days of antibiotics. What's the evidence for 10 days of antibiotics? It turns out the evidence is the number of metacarpal bones in the hominid hand, which has led several of us to speculate that the world might have been a better place with less antibiotic resistance if we had instead evolved as 3-toed sloths. And in fact, we were able to publish that speculation in a peer-reviewed article over the objection of the peer reviewer, who thought that that sentence was, quote, unprofessional. But I called the editor. This is a true story. I'm not making this up. I called the editor and I said, listen, when you asked us to write this paper, you knew I was nuts. And he goes, actually, I asked you to write the paper because I knew you were nuts. So go ahead, leave the sentence in. And so that's how it made it through peer review over the objection of the peer reviewer. And I now cite 3-toed sloths in the Shorter is Better lecture on all occasions, because 3 to 6 days is better than 7 to 14 days. Shorter is better is not just a fringe movement anymore, like it was at the very beginning. It's now mainstream. The largest physician society in the United States, the American College of Physicians, has come out with a position paper that short course therapy is now standard of care for many types of acute bacterial infections. Now, it's really hard to keep up with the evidence because so many trials have come out in such a short period of time. So I keep a running table on my website showing the list of all the randomized controlled trials that I can find in this space, comparing shorter or longer durations of therapy. And for all 24 of these disease conditions, in every single one of the more than 150 randomized controlled trials, 150, how many trials do you need? The short course regimen was always as effective as the long course regimen. And in many cases, the short course regimen was neither based on Constantine units or metacarpal bone hand numbers of people's hands. We don't have to fall back on those ridiculous decisions anymore. We can actually use evidence-based decisions for durations of therapy now. So I don't have time to go through all 24 of these diseases, obviously. I'm just going to go through the higher frequency ones, the more common ones. And we'll start with community-acquired pneumonia, because it was the first disease that was subjected to these trials. There are now 14 randomized controlled trials of community-acquired pneumonia. Nearly 9,000 patients have been randomized. And in every single one of these trials, 3 or 5 days was as effective as 7 to 14 days of therapy. How much data do you need? Are there seriously still people giving 10 and 14 days of treatment for community-acquired pneumonia? Why? The data are overwhelming. And in many of these trials, when at end of therapy, the respiratory secretions were sampled, not surprisingly, there was reduced emergence of resistance in patients given the short course therapy. Now, many, I would say 5 or 6 of the first trials of the 14 in pneumonia were of relatively milder patients, outpatients with pneumonia or ward level pneumonia, but not in the ICU. And that was one of the original complaints. Well, that's fine, but if you're really sick, you still need 14 days. That changed with this trial, published in 2016. This was the trial that the editorial naming the movement Shorter is Better was published to accompany. And in this trial, 40% of the patients enrolled had pneumonia severity indices of 4 or 5, the more severe types of pneumonia. And yet, across all outcomes looked at, across all subpopulations looked at, there was no difference in outcome between the normal duration of therapy and the shorter duration of therapy. And again, continuing additional analyses, no difference, no difference, no difference, except for one. There was one population that actually did do differently. And guess which population that was? It was the pneumonia severity index 4s and 5s, the sicker patients with pneumonia, who did statistically significantly better with short course therapy. So when this was published, people came up to me and they said things like, well, that doesn't make any sense. That would mean antibiotics are bad for you. And I was like, yeah, that's what it means, because they are. We have this unrealistic, naive belief that antibiotics are like manna falling from the heavens. They only do good and they do no harm, but we know that's not true. There are data that tell us every day you continue a patient on an antibiotic, you increase their risk of an adverse event by 4 to 5% per day, and increase the risk of resistant superinfections occurring. Let me ask you something. Which patients are more likely to get the acute kidney injury, the hepatotoxicity, the C. diff, the Pseudomonas, and the Candida superinfections? It's the sickest patients in the ICU are at much higher risk of all those things happening. This result makes perfect sense. Not only should you use short course therapy in people that aren't that sick, it's even more important to do it in people who are sicker, because they are at higher risk of harm and they derive no additional benefit. How badly do we overtreat pneumonia? People forget about the daptomycin experience. When Cubist was first developing daptomycin, it wanted daptomycin to be used for every infection there was. So they did 2 large phase 3 randomized controlled trials for community-acquired pneumonia without ever having tested daptomycin for pneumonia in an animal model. Oops. And they learned in these 2 randomized controlled trials that daptomycin was inferior as a treatment for pneumonia, but they didn't know why. So after the failure in these 2 trials, they went back and they did mouse studies. And that's when they first learned that pulmonary surfactant inactivates daptomycin. Might have been nice to know that before you spent $50 million on 2 randomized controlled trials. Nevertheless, there is an important lesson from these trials. To make the trials enrollable, the protocols allowed 1 dose of ceftriaxone to be given before patients were randomized to daptomycin or continued ceftriaxone. And it turns out that patients in the daptomycin arm who did receive 1 dose of ceftriaxone had much higher cure rates than those who did not. 1 dose of ceftriaxone probably cures 40% of patients with pneumonia, and we've been historically treating for 14 days. You don't need to do that anymore. 3 to 5 days is adequate. Well, what about ventilator-associated pneumonia? Now, these patients are the sickest patients in the hospital. They're in the ICU. They have a mechanical ventilator. They have a foreign body in place with that endotracheal tube. They have the most resistant pathogens we encounter. And yet, 3 randomized controlled trials have now showed that 5 days to 8 days, between 5 and 8 days, is as effective as 10 to 15 days of antibiotics therapy for these patients. I really like this study. I find this study extremely funny. It's very hilarious to me. This is not a randomized controlled trial. This is a retrospective study of patients treated at the Brigham and Women's Hospital, which is one of the Harvard teaching hospitals, which makes it even funnier to me that they did this at Harvard, okay? So what they did is they looked at patients who had, quote, suspected ventilator-associated pneumonia. And they asked the question if those patients did better getting more than 3 days of antibiotics or not. Now, the trick was this, what was suspected, what did that mean? Suspected ventilators? So what does that mean? That meant that patients grew bacteria from the airway and the doctor gave antibiotics. That was the definition of suspected ventilator-associated pneumonia. Now, the problem is every single patient in this study was normally oxygenating. They were on 40% FiO2 or less and low PEEP. So they had no evidence of deoxygenation, but they still had, quote, suspected VAP. And it turned out getting more than 3 days of antibiotics made no difference. Again, across all population and endpoint looked at, giving more than 3 days or less than 3 days made no difference. So the author's hilarious conclusion was patients with suspected VAP who are ventilating normally don't need more than 3 days of antibiotics. I don't know how this conclusion got past the peer reviewers and the editor. My conclusion from this study is that patients who don't have pneumonia don't need more than 3 days of antibiotics because these patients didn't have pneumonia. They were oxygenating normally. Nevertheless, I will go back to what Lou Rice pointed out in 2008. If you're going to give patients who don't have infections antibiotics, at least do us the courtesy of doing it for a short period of time, and I'll still count that as a win. Now, what about complicated urinary tract infections and kidney infections? There are now 13 randomized controlled trials, more than 3,000 patients, showing that 5 to 7 days is as effective as 10 to 14 days. This does now include 2 trials exclusively done in men, and it now does include not just the fluoroquinolones, but Bactrim as well. So people say to me, but you don't understand, my patient's diabetic, so I need 14 days. And I say 40% of the patients randomized in these trials were diabetic. They did just fine with 5 to 7 days. But you don't understand, my patient is bacteremic, so I need 14 days. 10% of the patients enrolled in these trials were bacteremic. They did just fine with 5 to 7 days. You don't need 14 days of antibiotics, even in patients who are bacteremic and diabetic. Now, the 13th of these trials is confusing to people. So I want to go through it in a little more detail because people have misinterpreted it. So there were 12 very simple, clean trials showing no question shorter was better. And then the 13th trial was published, and that was this trial, the ProstaShort study. which when it was published, people came up to me and said, see, we told you you can't give 5 to 7 days of antibiotics for this disease. And I was like, calm down, calm down. First of all, there are 12 other trials, so calm down. And second of all, I think you've misinterpreted this trial. So let's go through it. This trial has 3 fundamental problems. First, they called it ProstaShort, which makes you think, oh, they're studying prostate infections because it's called ProstaShort. But if you look in the methods, they tell you that they excluded prostatic abscesses from the trial. So I'm like, is this an ironic name? Is this like when you call a tall person shorty? Why did they call it ProstaShort and then exclude prostate infections from the trial? These were not, in fact, prostate infections. They were men with urinary tract infections who had a fever, excluding prostatic abscesses. Here's the second problem with this trial. How many of you have prescribed ofloxacin? Do you use a lot of ofloxacin in the Ukraine? I've never prescribed ofloxacin because as old as I am, and I'm pretty old, by the time I started practicing, ofloxacin was kind of off the market. And the reason was the company that sold ofloxacin wanted to renew its patent. And it discovered that ofloxacin was a mixture of L and D enantiomers. And all of the antimicrobial activity was in the L or levo enantiomer of ofloxacin. So they came up with a manufacturing method to purify levofloxacin, and they got a new patent and called the drug levofloxacin, which is what everybody started to use. So they dosed ofloxacin in this trial at 200 milligrams twice daily, which is a levofloxacin equivalent dose of 100 milligrams twice daily. Now, I don't know about you all, but when I prescribe levofloxacin, I dose it at 750 milligrams a day. Who's given 100 milligrams of levofloxacin? Are you really serious about this right now? They gave a hilariously low dose of drug in this trial. And then here's the third problem with this trial. They used the United States FDA endpoint, which is a terrible endpoint that people like me have been yelling at the FDA about for years, but it's still the FDA endpoint. And it requires 3 things to be true. To be a success, the symptoms of the infection have to go away, which is good. You can't relapse, which is good. But then there's the third problem. You also have to have a negative urine culture 4 to 6 weeks after the end of therapy. Now, look, folks, I don't know about you, but when my patients are cured, I don't randomly check urine cultures in asymptomatic people 6 weeks later. What a stupid thing to do. But you had to do that for this endpoint. So let's look at the results. Oh my goodness, the shorter arm had a lower success rate at 56%. See, we told you can't use shorter therapy. Yes, true. But the reason it was shorter was because there were more asymptomatic bacteriuria patients in the shorter arm 6 weeks later. If you looked at the resolution of symptoms, there was no significant, look at this, 96% of patients given a hilariously low dose of levofloxacin equivalent had clinical success, and there was no difference in relapse. The only difference was patients had a higher rate of still carrying bacteria asymptomatically in the urine 6 weeks later. So I think the lesson from this trial is use a real antibiotic at a real dose and don't check urine cultures in asymptomatic people 6 weeks later, and you're going to be fine. What about intra-abdominal infections? We have 3 randomized controlled trials showing that 4 days of antibiotics after source control is as effective as 8 to 10 days. And in fact, for appendicitis, we have trials showing that 1 to 2 days of antibiotics is as effective as 5 to 6. Now, this doesn't mean total duration of therapy. If it takes you 3 days to go to the OR to drain the abscess or control the infection, it's 4 days from that time. This is days from source control, not total days for intra-abdominal infections. So we've talked about pneumonia, we've talked about urinary tract infections, and we've talked about intra-abdominal infections. Those are the 3 places gram negatives come from. Maybe it's not surprising that we also now have 4 randomized controlled trials of patients with gram-negative bacteremia. In the first 3 trials, 1,356 patients randomized to 7 or 14 days, no difference in outcome. This included a substantial number of people with active cancer and or who had received a transplant. And it included all types of gram-negative bacteria, including Pseudomonas. No difference in 7 versus 14 days. The 4th trial is larger than all of the other 3 combined. It was just published recently. 3,600 patients with a variety of types of bacteremia did not have staph and did not have candida, but had everything else. But 85% of them were gram-negatives. These were sick patients. More than half were enrolled from the ICU. All sources were included. You can see that the majority of patients were gram-negatives. They did have Enterococcus and strep as gram-positives as well. Pseudomonas accounted for 80 patients in the short course arm and 90 in the long arm. So this Pseudomonas is in there, Enterococcus is in there. No difference in clinical cure. There was no statistical difference in death, but in fact, there was a strong trend to lower mortality in the short course therapy arm. Patients who got treated for longer had a trend to higher mortality, and this was true across all subpopulations looked at. So the data are overwhelming now. 5,000 patients with bacteremia have been randomized. You do not need to give 14 days of therapy for bacteremia anymore. What about skin infections? There are 3 randomized controlled trials. This includes cellulitis, major abscesses, and wound infections. 5 to 7 days is as effective as 10 to 14 days. Even bacterial meningitis. Are you kidding me? We have a large randomized controlled trial of kids with purulent bacterial meningitis, 1,000 patients randomized. 5 days was as effective as 10. And in 5 smaller trials, the same thing was seen. So there's actually 6 randomized controlled trials showing that 4 to 7 days of antibiotics is as effective as 7 to 14 for bacterial meningitis. You're telling me I can cure bacterial meningitis with 5 days of antibiotics, but I need 14 days for a cellulitis? Really? Come on. Okay, now people get confused about osteomyelitis because they're like, well, we still have to give many weeks so that you treat shorter. That's actually not true. We have 2 large randomized controlled trials showing that 6 weeks of therapy is as effective as 12 weeks. So yes, 6 weeks is more than 10 days and 5 days, but it's still shorter than 12 weeks. So we've been moving shorter and know that we don't need to give more than 6 weeks of treatment for a chronic osteomyelitis. Now, there are small trials. These are 30 or 40 patient trials, suggesting that in some cases you might even be able to give 3 to 4 weeks. And I think we need a larger definitive trial to move us from 6 down to 3. But I know that in Europe, a lot of people do regularly use 4 weeks with very good outcomes. I think we do need a study to see if we can move shorter from there. This is the point in the talk where the infectious disease experts usually stand up and start throwing rotten fruit and vegetables at me. Because I'm going to tell you that you don't need more than 3 to 5 days of antibiotics for patients with acute exacerbation of chronic bronchitis, COPD, or sinusitis. And you're going to yell at me and say, well, of course you don't need more than 3 to 5 days. These are caused by viruses. You don't need any therapy for them. And I'm going to return to what Lou Rice said in 2008. That's true. But it's still a win. If somebody's going to give antibiotics, let them give 3 to 5 days. It's still better than giving 7 to 14 days for these patients. Now, I don't know about you, but the hematologists drive me crazy. And it's not because they're bad people, it's just that their patients are on 14 antibiotics for 27 years and it drives me crazy. Okay? So imagine my delight when this study was published in a hematology journal. Can you imagine the glee I experience when I take care of a patient with neutropenic fever and I print this study off the web and hand it to the hematology team from their own journal? I'm like, why are you still giving antibiotics? Your own study from your own journal says you don't need to do that anymore. So these were not just regular neutropenic fevers. These were the highest risk neutropenic fever patients. Every patient either had an active leukemia or were status post stem cell transplant. And they were randomized to receive antibiotics until the normal duration of therapy, which was not only did you have to be afebrile, but you had to be not neutropenic anymore. So you were going to stay on antibiotics until you were not neutropenic anymore, or stopping antibiotics when the patients were afebrile for 72 hours and clinically stable. And guess what they found? No significant difference in death, although numerically, the death rate was lower in the short course arm, but there was a massive difference in serious adverse events, more than double the rate of serious adverse events in the traditional duration arm, because there were more C. diff and superinfections in that arm. Again, who gets the C. diff? Who gets the Pseudomonas? Who gets the Candida? It's the sickest patients in the hospital who are on antibiotics for weeks. This result makes perfect sense. We now even have a large observational study applying the how long study criteria to a real world cohort. In this study, half the patients in the short course arm not only had neutropenic fever, they were bacteremic, and they still applied the how long criteria. And the patients that got the short course how long criteria had significantly less death. So, are there exceptions? Yeah. And people like to say TB is an exception. I'm not sure I agree with that, and here's why. We still give many months of treatment for latent TB, but we used to give 12 months, and now we can give 3 to 4 months. So we've been moving shorter as randomized controlled trials have been done. For pulmonary tuberculosis, before PZA and rifampin came along, we used to treat for 3 years. And then it became 6 months. So we did move shorter. And now we have trials suggesting with newer drugs, we can get down to 4 months. And it looks like 2 months may be too short. So somewhere around the 3 to 4 month is maybe where we're heading to with these combinations of newer drugs. Is it longer than 5 days? Absolutely. But this is a strange disease. The point is it's way shorter than it used to be. So we have moved shorter as randomized controlled trials have been done. But there are absolutely exceptions. Okay, there's a few clear exceptions. First, prosthetic joint infections. We had the large randomized controlled trial, the DTIPO trial, published in 2022, which clearly showed that 12 weeks of therapy was superior for cure compared to 6 weeks for prosthetic joint infections. Now, I will point out all of the superiority was in the patients who had the implant retained and debrided. For patients who had exchange of the device, if the device was taken out and exchanged, there actually wasn't a difference between 6 and 12 weeks. So this is really true for patients if you're going to leave the device in place and debride it, but not necessarily true if you're going to exchange the device. There is a large randomized controlled trial of children under the age of 2 with otitis media, showing that 10 days was clearly superior to 5 days. However, there are multiple other trials of children over the age of 2 showing that 10 days was not superior. So I think for otitis media, it depends on the age of the child. And I don't know why under the age of 2 is less effective for short course therapy. I don't know if that's a dosing problem, a compliance problem, but I believe it's true. I also believe, based on the trials, if they're over the age of 2 years, you don't need more than 5 days. And then there's strep throat. Now, I am not a pediatrician. I'm an adult ID guy. I see almost no strep throat. And I don't know why the pediatricians got so mad at me, but a few years ago, I published an article on short course therapy on Medscape on the web, and I got blasted by the pediatricians who were very angry about strep throat. I don't know if the pediatricians are wearing too many bow ties. I don't know what the problem with the pediatricians is, but they were very mad at me. So I decided to go look at strep throat. And it turns out the pediatricians were right. For strep throat, if you give thrice daily oral penicillin, 7 to 10 days is superior to 3 to 5 days. However, angry pediatricians, I will point out, if you use an oral cephalosporin instead of penicillin, 7 to 10 days is not superior. And there was a fascinating trial done just a few years ago where the investigator said penicillin is a time-dependent killer and it has a short half-life. Maybe we should dose it 4 times per day instead of 3 times per day. They compared 4 times per day penicillin for 5 days to 3 times per day penicillin for 10 days, and there was no difference. So for strep throat, it depends on which drug you use and at what dose. Now, I get a couple of very common questions, frequently asked questions. Let's just get these out of the way and then we'll wrap up. Are you really telling us that no one can ever receive longer therapy for these patients? No, I'm not saying. I don't know why people think I'm saying that. I didn't say that. Did you hear me say that? No, I didn't say that. We're talking about moving the average duration of therapy shorter. There are unique patient circumstances that come up. Remember that to get into these trials, you had to be getting better. If your patient isn't getting better at the end of 3 or 5 days, they're not eligible for short course therapy. You need to give a customized duration of therapy. You should also be asking yourself, why are they not getting better? Is there a source control problem? Is there an abscess that needs to be drained? Maybe this actually isn't an infection. Heart failure and pulmonary embolus can look a lot like pneumonia. Dermatitis can look a lot like cellulitis. So yes, sometimes you need to give longer courses of therapy. When you do that, you should be thinking, is there something else going on? And then I get a series of common questions that I call the what about questions. And Dr. Sapansky hit me with one of these questions before the lecture, mentioning cystic fibrosis. So I get the what abouts. But what about typhoid fever? What about chronic prostatitis? What about actinomyces and non-tuberculous mycobacteria? What about Staph aureus bacteremia? What about cystic fibrosis? And my response is, yeah, what about them? I don't know. I don't have randomized controlled trials to answer the question. See, this is the problem. I have an undeserved reputation for being a maverick. I'm actually not a maverick. This is me without data. If I don't have data, I'm a chicken. It's just that when I have data, I turn into that. So this maverick thing is just based on data. If I don't have data, I don't know the answer. We need to do those trials to answer the question. Now, finally, and this is the last thing, and then we wrap up. Who amongst us has not heard this said to patients? Who amongst us has not said this to patients? If you want to prevent antibiotic resistance, take every last dose of antibiotic your doctor gives you, even after you feel better. This is utter nonsense. And it was actually Lou Rice who pointed out in the same lecture in 2008 that this is nonsense. It is based on no data whatsoever. And in fact, it makes no sense. This is not how natural selection works. If you want to cause resistance, give more antibiotics. If you keep taking the antibiotics after you feel better, you can't get any better than feeling better, but you can cause resistance. So we need to stop saying this to our patients. In fact, if you give 14 days of antibiotics to a patient with a kidney infection or a skin infection, they're going to be feeling better a lot earlier than those 14 days. But if you just give 3 to 5 days of antibiotics in the first place, they're not going to be feeling that much better before they finish the antibiotics. You're going to obviate this concern in the first place by just moving to short course antibiotic regimens. So, statistically speaking, based on past experience, I have likely put approximately half of the audience into coma. So anybody who's not in coma, please extend your elbows in both directions and push outwardly to wake up the people in coma. Because really the only thing you need to know from this entire painful experience that you spent with me are these 3 things. We really need to do a much better job preserving the antibiotics we have. We have data from many types of infections showing that short course therapy is as effective as longer therapy and doesn't drive resistance and avoids adverse events. So basically, all you really need to remember is that shorter is better. And with that, I will stop and you may open up the field to questions.
This is amazing, Dr. Spelberg. Amazing. Thank you so much. Dear audience, do you have any questions?
Yes, if you mind.
Julia, yeah, please.
Yeah, first of all, we sincerely thank you for taking the time to give us this very interesting lecture because, in our hospitals, doctors use it completing the courses, and we have so very long time to.
Mhm.
And despite strong evidence, short course therapy still faces limited adoption due to skepticism or fear in clinical practice. How can we, young researchers, meaningfully influence clinical implementation through publications, advocacy, or education?
I think you just said the three key words. Publications, advocate. That's exactly right. So,
Okay.
so don't feel bad. We all go through this. This is really hard to change. It's deeply embedded in culture all over the world to use long courses of therapy. It's taken years locally for me, and I'm the freaking chief medical officer. It's taken years to get me to get, but we're there now. And so I like to use, do you remember the movie Finding Nemo?
Yes, sure.
Do you remember Dory? Just keep swimming.
Yes.
Just keep swimming. Just keep it. You're gonna get there. You've said the exact right ways to go about it. Your advocacy and continually reminding people about the data, you will get there.
Okay, and as always, Dory has problems with the
Short-term memory.
Yes,
That's
and
right.
they just remember for the 3 seconds all the information that we talked to them.
Exactly. So you just have to keep reminding them. Just keep swimming. Yep.
Okay, thank you so much.
Beautiful question. So, if you don't mind, I would like to ask my questions. So, on my way of thinking, in my experience, the one of the most or the nastiest problems in Ukraine now, this is Neisseria gonorrhea and multi-drug resistant gram-negatives, wound infections. So I didn't notice that you showed some data from that. Do you have some information for this problem, or it's like
There are, unfortunately, Dimitro, there's no randomized controlled trials for gonorrhea that I'm aware of comparing duration of therapy. There is for wound infections. The skin and soft tissue infection trials combine 3 disease types: cellulitis, major abscess, and wound infections. So it's the same 5 to 7 days of therapy for those from 3 randomized controlled trials, with the following caveat. Doctors all over the world seem to believe that humans have no bacteria on them normally. So like when bacteria grows, they're like, oh my God, there's an infection. And I'm like, actually, you have bacteria on you right now. In fact, you have more bacteria on you right now than you have your own cells in you right now. So why are you surprised when you grow bacteria from a wound? Of course, there's bacteria on the wound. There's supposed to be bacteria on the wound. And so what the point I'm making, I'm being sarcastic about it, but here's the real point. Is it really a wound infection? Or is it just a culture that's positive from the wound and we're over-treating, causing the very resistance that's freaking everybody out? Is there pus? Is there erythema, pain, and swelling? Or is it just, actually, it's granulation tissue and I swabbed it and it was a resistant gram-negative that I should ignore?
Yeah, thank you for your answer. Yeah, it's really important. And so, as an American Society Ambassador to Ukraine, and this event, this beautiful lecture, is under umbrella of this beautiful society. So, I would like to ask, what role should professional health associations like ISM and other associations like infectious disease and College of Physicians play in promoting uptake of shortened therapies? Do you have any suggestions or maybe
Yeah.
experience or maybe recommendations?
Yeah, specialty societies carry a lot of influence with their members. One of the ways they do that is by publishing guidelines, but it's not the only way. And they need to follow the data. You know, for years, specialty societies continued to push incorrect durations of therapy, as well as other incorrect types of care, because the guidelines were completely wrong, not based on data or out of date. So we need to follow the data. Again, you don't have to be a maverick. I'm a chicken. But when I have randomized controlled trials, we can follow the trials. That's what specialty societies should be doing, is reminding people, helping you, Lila, remind people about the short course therapy data. It's not because it's, you know, different that we do it. It's because it's based on reproducible, high quality evidence. And that's what we need to reminding people about.
Remind and doing, and we need time for this.
Amazing.
Yeah.
We have other questions. So if the patient getting 2 antibiotics, or sometimes it's 3 antibiotics, I remember that happened during the COVID-19. So what the tactic in that case?
Yeah, I mean, that's a little different than duration. I have actually a separate talk on antibiotic stewardship generally, which I'd be happy to come back and give it another time. But the short answer is, if you don't need 2, use 1. Like, multiple studies across multiple disease types have showed that combination regimens are not more effective than single therapy as long as the single drug is effective. This is obviously not true for tuberculosis. TB is a weird disease. You got to separate it out. For most acute bacterial infections, there's no benefit to combo therapy. If you have one drug that's effective, that's active in vitro, use the one drug.
Thank you. And so we don't have so far any questions, but I have a last question, I promise.
Okay.
So the new mantra is, I remember you mentioned shorter is better. So my question is, what the on your way of thinking, what the future mantra in terms of duration of antimicrobial?
I'm curious to find out. I mean, oral is the new IV, is the other one that I've coined. We're going to learn as trials are done. I mean, that's the thing. That's why we do those trials. And so because I was an early adopter on shorter is better, people think I'm like this, how did you invent? Like, I just followed the trials, guys. So I don't know what the future will bring, but whatever it brings, we should follow the data.
Thank you. Thank you. So we don't have any questions, and thank you for your time, and thank you, Dr. Spelberg, for your remarkable insights and leadership in this critical space, and your work continues to reshape how we think about infection treatment and also antimicrobial stewardship. Dear participants, thank you for joining this special event organized by the SM in Ukraine, and we really encourage you to continue this conversation within your institutions and network.